Assalamu alaikum. Today we're going to be talking about the congenital abnormalities of the small and the large intestine, and this presentation is actually presented by Amal of Medicine. To start with, we're going to start with the first congenital anomaly, which is obstruction. By obstruction, I mean anatomical obstruction of the intestine. Now, thinking about obstruction, you would think that something might be totally obstructed or it might be partially obstructed. If it was totally obstructed, it's going to be called atresia. By atresia, I mean that there is total or complete obstruction of the intestine due to the failure or complete failure of development of the intestinal lumen. The second choice could be incomplete obstruction or partial obstruction leading to narrowing of the lumen, which is called stenosis. These two anomalies can occur in small and large intestine, but the most common position or the most common site of atresia is the duodenal atresia. You have to keep this in mind. Moreover, 30% of children with Down syndrome usually have duodenal atresia. This is the first congenital anomaly. Now, you can see from these pictures, for example, this is a picture of duodenal atresia. You can see that there is narrowing or stenosis of them. Obstruction, not narrowing or stenosis, because it's atresia of the intestine. The second congenital anomaly that we're going to be talking about is called the omphalocelli. By omphalocelli, I mean that there is a defect in the pre-umbilical abdominal musculature. Now, this defect is going to create a sac, as you can see from the picture up here. It's going to create a sac, and through this sac, you're going to see some intestinal herniation. On the other hand, there is another anomaly called the gastroschitis, and this gastroschitis is going to be a condition where you're going to have lack of formation of a part of the abdominal wall. Because you don't have a part of the abdominal wall, this is going to lead to the extrusion of the intestine through one side of the umbilical cord. But what's the difference between these two anomalies? In this anomaly, you're going to find that the herniated part is going to be herniated within a sac. So it's going to be closed by this sac. Whereas here, the herniated part is not going to be herniated throughout the sac, which means that the intestines are going to be herniated by a side or through one side of the umbilical cord freely outside. This has been the second and the third anomalies, which we already finished from. The fourth anomaly is malrotation. From the name, malrotation, what do I mean by malrotation? Malrotation is going to be that something is going to be positioned in a position which is actually not its original position or its normal position. Now, in this condition, you're going to see that there is abnormal intra-abdominal position of the intestine. This is going to be like an illustrative picture of malrotation. And because you're going to have abnormal position of different intestinal structures, sometimes you can find the cecum in the left upper quadrant. And this is going to produce the fact that the intestines are going to be more predisposed to volvulus. What is volvulus? Volvulus is going to be obstruction within a loop, which means that something is twisted and therefore it's going to obstruct the intestine. Sometimes in people who have this problem, which is malrotation, appendicitis could be usually present as left upper quadrant pain, and this is going to produce some confusion in clinical symptoms of appendicitis. So this has been malrotation. The fifth congenital anomaly to be described today is duplication. What do I mean by duplication? From the basic meaning of duplication, duplication is going to be when I already have a piece of the intestine which is going to be, or the piece of a bowel which is going to be pinched off, and it's going to be adjacent to the small intestine. Now, it could take lots of shapes, but one of the shapes could be saccular or tubular cystic. As you can see in this picture, it's cystic shape, and it may or may not communicate with the small intestine. Here, this duplicated sac or this duplicated piece is communicating. Here, it's not communicating. One of the most important anomalies is called the Meckel's diverticulum. Before starting with details regarding this anomaly, we're going to be talking about diverticulum in general. What is meant by diverticulum? Actually, diverticulum means an outpouching of a hollow organ or a hollow sac or a hollow structure or a fluid-filled structure out of the body. And this picture basically illustrates an example of diverticulum, because you can see that there is an outpouching of our abnormal outpouching of a part of the intestine here. And why would Meckel's diverticulum occur? Meckel's diverticulum occur usually because of the outpouching of the ileum due to the presence of the part of the yolk sac. In other words, we could describe it as the failure of inovulation of the omphalomesenteric duct. By inovulation, I mean folding, normal folding during embryonic life, which actually leads to tubular protrusion, as you can see in this picture, or also it could be demonstrated from this picture where you're going to have an outpouching. Usually this diverticulum or this anomaly is going to be asymptomatic, but it can cause some complications. One of the most important complications to be caused are valvulus inflammation. They're going to be valvulus inflammation, peptic ulceration, and intussusception. Okay, and also another one complication which might happen when you're going to have bacterial outgrowth, which basically depletes the vitamin B12 and produces a syndrome which is going to be similar to pernicious anemia. Accounting for the fact that this is going to be a sac, an outpouching sac, abnormal outpouching sac of the intestine, you might predict that some stuff might be like stuck in this sac. So sometimes we might find some pancreatic cysts and gastric mucosa in this Meckel's diverticulum. Regarding the Meckel's diverticulum, there are specific points that you have to always keep in mind. It's going to be called the rule of 3 2s in Meckel's diverticulum. The first thing to remember is that the prevalence of the Meckel's diverticulum is 2% of the population. This is our first 2. And also remember that it's going to be more in males than females. The second thing to remember is that the site of it is going to be 2 feet from the ileocecal junction. 2 feet means 60 centimeters, but usually it's going to be 60 to 80 centimeters from the ileocecal junction. And the third 2 to remember is that the length of it, which is going to be 2 inches, 5 to 6 centimeters. So keep in mind the 3 2s of the Meckel's diverticulum, the prevalence, the site, and the length of the Meckel's diverticulum. The next anomaly that we're going to be discussing is the megacolon. Megacolon means an enlarged colon because mega means that something is large. This anomaly could occur as a congenital anomaly, which is called Hirschberg's disease. On the other hand, it could be an acquired anomaly, which is usually called megacolon and sometimes called toxic megacolon when it's going to be present as a complication of ulcerative colitis. What is megacolon and how would it occur? Basically, megacolon is going to be let's start by describing the congenital megacolon, which is going to be a dilatation of the colon due to the absence of normal mesenteric plexus distal to the dilatation. So I'm going to have abnormal mesenteric plexus or the absence of the mesenteric plexus itself. Usually it occurs because of the migration of the neural crest-derived cells along the alimentary canal are going to be arrested before they reach the anus. If you want to evaluate the megacolon microscopically under the microscope, we already said that we're going to have an absence of the normal mesenteric plexus. Therefore, if you viewed it under the microscope, you're not going to find normal mesenteric nor submucosal plexus. On the other hand, you're going to find hypertrophy of the nerve fibers within the submucosa and the muscularis mucosa with extension of the abnormal axiom into the lamina propria. Whereas macroscopically, in congenital megacolon, you're going to find narrowing of an abnormally innervated bowel segment and dilatation and muscular hypertrophy of the proximal bowel segment. Usually this dilatation or muscular hypertrophy is going to be as a compensatory mechanism, whereas if you're talking about the acquired megacolon and not the congenital one, you won't find narrow segments. The dilatation is going to be down through the anus and the rectum is going to be filled with feces. Let's start with the congenital megacolon, which is Hirschberg's disease. As you can see here in this image that there is a dilatation of the colon, and the colon is going to be mega in size, which is really large in size. The clinical features of congenital megacolon, usually it's going to be present in early childhood, and you're going to have symptoms of colonal obstruction. These symptoms may include constipation, abdominal distension, and may include vomiting as well. And to diagnose this case, usually we need radiological examinations, which is something very easy to think of because megacolon is going to be very clear in radiological images. On the other hand, you can use sometimes small barium enema or barium amounts to demonstrate a small empty rectum with a narrowed segment above. This is the narrowed segment above, and this is going to be the large megacolon. And you can see that we have wide dilatation of the colon, and this wide dilatation of the colon is going to be full of retained feces. Okay, because it's going to be megacolon, so it's going to be dammed and full of feces. And to confirm this diagnosis, usually you need the biopsy of the rectal mucosa in order to confirm this diagnosis. And when you have a rectal biopsy, what are you going to be finding? As we already mentioned, you're going to be finding the microscopic demonstrations of a megacolon, where you won't find any normal mesenteric or submucosal plexus. Regarding the genetics of this congenital megacolon, many cases have been accompanied with RET gene mutations and RET ligands. Why is that? This is because this signaling pathway is required for the development of the myoenteric nerve plexus and provides direction to the migration of the neural crest cells, which was basically the basic problem in the megacolon, in the Hirschberg's disease, where you're going to have abnormal or arrest of the neural crest derived cells along the alimentary canal before they reach the anus. The second mutation that's usually accompanied with this anomaly is the endothelin 3 and the endothelin receptor mutation. Remember, that's going to occur in 1 in 5,000 to 8,000 births, predominates more in males than females, just like the Meckel's diverticulum, and usually it occurs, or it's more frequent in babies or infants who are already having other congenital anomalies like hydrocephalus, ventricular septal defect, and Meckel's diverticulum. Moving to the acquired megacolon, here I actually included a radiological picture of the acquired megacolon, where you can notice that we're going to have an enlargement of the colon in this picture, and usually it's going to be filled with retained feces. What are the causes of congenital megacolon? The first thing is going to be called the psychogenic megacolon. This is going to be a condition where you have disregard for the urge to defecate. The other one is going to be the prolonged laxative abuse. Why? Because the laxative abuse for a long period of time could cause degeneration of the myenteric plexus. The third reason is the smooth muscle disorders, where it might cause degeneration of the colonic smooth muscles, such as, an example is the scleroderma. The fourth reason is the Shaggy's disease. Shaggy's disease is really common in South America. It's going to be infection by Trypanosoma cruzi, and this is going to lead to destruction of the myenteric plexus. Obstruction, which is usually any obstruction which might be caused, but as an example, let's say a polypoid colorectal carcinoma can cause obstruction leading to megacolon. And the last reason is the toxic megacolon. As I already mentioned, it's a complication of untreated ulcerative colitis or ulcerative colitis in general. Proceeding to the anorectal anomalies, one of the most common anorectal anomaly is called the imperforate anus. By imperforate anus, I mean that there is a missing opening of the anus. So the anus is going to be normal in its position, but there is a thin layer of tissue, as you can see here. There's a thin layer of tissue that's going to separate the anus from the exterior. And this membrane is going to be really thin, that's going to be enough to bulge on straining. Usually this anomaly occurs more in males than females, but to diagnose this case, you have to have some signs and symptoms. One of the most important signs and symptoms that the baby or the infant is not going to pass stool within the first 24 to 48 hours of his birth. That's one of the symptoms. Sometimes you might notice that the baby is going to have a swollen belly. Sometimes the baby is going to pass stool out of the vagina, out of the penis, the scrotum, or the urethra even. And sometimes you're going to see that there is a missing opening of the anus, as you can see here. And also in females, one of the signs is that you're going to see that the anal opening is really very much close in position to the vaginal opening. Proceeding to our last anomaly to be talking about today is the anorectal agenesis. In this case, you're going to find that the rectum is going to end superior to the puborectalis muscle. It can occur with a fistula or without a fistula, and this is an image which illustrates that the anorectal agenesis occurs with a fistula, which you can see it up here. So thank you very much for watching. This video has been talking about the congenital anomalies of the small and the large intestine. These are the two reference books that I used for extracting the information for this lecture. If you have any feedbacks, questions, or suggestions, please contact me at this email. I'd like to hear your feedbacks and hope you have a really nice day. Assalamu alaikum.